Waiting for you. Okay, we're going to get underway. Good afternoon. My name is Bill Monning. I'm the recently appointed chair to Health Committee. I look forward to this charge, look forward to working with members of this committee, staff, and those of you with issues before our committee today. We, I think, are shy of a quorum right now. We will commence as a subcommittee. And as we do that, we will be first hearing Ms. Yamada's bill, AB 1593. If you'd like to come forward, I would remind all presenters that we allow 2 witnesses per side with a time limit of 3 minutes each, and we will keep track and give you some alerts as we approach your time terminating. We'll also allow for public comment from the microphone. Would ask you to identify yourself by name and organization and record your position on the measure. That would be for additional witnesses. As we proceed, we will perhaps pause once we establish quorum. We are proceeding as a subcommittee. Welcome, Ms. Yamada.
Thank you, Mr. Chairman. It is my privilege to be first up at your first committee hearing, and I am presenting today AB 1593, which is actually the same bill that I presented last year as AB 369. It did make it to the governor's desk and was vetoed. We are hopeful that by working with the administration we can persuade them that to exempt 2 existing adult day health centers that are co-located with veterans homes in Lancaster and Ventura, that we may be able to provide suitable services to veterans who are in need of day treatment, adult day activities. We know that the return rate for our veterans from the global war on terrorism and their concomitant injuries and illnesses could benefit from these services co-located at the veterans campuses. I did have the opportunity to attend the grand opening of the Lancaster facility, and I can tell you the Adult Day Health Center there is gleaming and ready to go and could definitely benefit from drawing down federal funds that have been left on the table by the governor's veto. In keeping with his message at his State of the State address, that we should be drawing down as much federal support as we can. I believe that our bill, which as I say is the same bill as last year that did reach his desk with no votes throughout the process, will hopefully have a better chance. So with that, I respectfully ask for an aye vote. We do know that adult day health is a controversial issue with the administration. We know that there are budget statements that have been made to eliminate adult day health as program services in California, but I think this would be a very grave mistake and a step backwards as we are addressing these growing needs in the community. So with that, I am happy to ask any questions. I believe we have a couple of witnesses in support and respectfully ask for your aye vote. Thank you.
Thank you, Ms. Yamada. If you'd like to present your witnesses.
Yes, please.
Thank you.
Go ahead. Jennifer Gabalis.
Hello, good afternoon. Thank you for your time today. I'm Jennifer Gabalis with the California Association for Adult Day Services. We are pleased to sponsor AB 1593. As Ms. Yamada stated, this bill creates an exemption to the ADHC moratorium on Medi-Cal certification to permit 2 ADHCs operated and owned by the California Department of Affairs to become eligible for Medi-Cal reimbursement. The federal match for ADHC reimbursement is currently 61.5%. Without certification, these facilities would be operating solely on their general operating funds and wouldn't receive any federal match for the services that they provide. The centers are located on 2 veteran campuses that were funded from a grant from the United States Department of Veteran Affairs. General obligation bonds and revenue bonds. So these were publicly funded facilities, and we respectfully ask for your support.
Thank you.
Good afternoon. My name is Kristen Heyman with Aging Services of California. On behalf of our home and community-based service providers, we are in support of AB 1593. The California Department of Veterans Affairs, as Ms. Yamada stated earlier, operates the veterans' homes with campuses in Yountville, Barstow, Chula Vista, and is constructing 3 new veteran homes in Ventura, Lancaster, and West Los Angeles. If AB 1593 is signed into law, 2 of these 3 sites nearing completion would be able to incorporate ADHC services into their long-term care options. If the 2 facilities are able to get certified as Medi-Cal providers, then they are able to receive federal funds from the Medi-Cal program. Community-based services such as ADHC are a cost-effective alternative to institutionalization and provide substantial savings to the state. The annual cost associated for an ADHC participant is around $11,000 compared to $55,000 for institutional care. That being said, this bill could improve the care of veterans living in these communities, which are in need of skilled nursing level of care, and it also saves the state money. Therefore, we respectfully ask your support of AB 1593. Thank you.
Thank you. Other witnesses in support of the bill?
Thank you. Dana Nickel with Pete Conity and Associates, representing the California Association of County Veteran Service Officers in support of this bill. Thank you.
We don't have quorum. Thank you. Any others in support? Are there any witnesses in opposition? Any questions from committee members? Mr. Adams.
Thank you very much, Mr. Chairman. Ms. Shimada, I think this is a very noteworthy bill, one that I'm happy to support, and when a quorum is present, I'll be making the motion to see it pass.
Thank you very much, Mr. Adams.
Mr. Nava?
Yeah, if you could repeat for me that figure that you told me, how much it costs for at the adult daycare as compared to institutionalization?
It's $11,000 versus $55,000, approximately.
Right. And of that $11,000, how much of that is paid for by federal monies?
It's 60 what percent? 61%, 61.5%.
So
I would have that in my head.
the state is actually, it costs the state 40% of $11,000, right?
Yes. Well, 39.5 if you want to get exact.
All right, 39.977.
Yes.
But I do think that that's part of the argument that has to be emphasized, is that, you know, as the budget committees go through these and try to make an assessment about which programs ought to be cut, instead of a rather primitive MEDAX approach, we need to take into consideration how much federal money we're leaving on the table.
Yes.
And these are and the adult day health care provide significant services for people in all of our districts, and I know most definitely in my district, the 35th Assembly District, it is just invaluable.
Thank you very much, Mr. Nava.
Thank you, Mr. Nava. Any other questions from committee members? Ms. Shimada, we have not yet established a quorum, so we will hold your bill till we establish a quorum and entertain motions at that time.
Thank you,
for your
Mr. Monti. If
presentation.
I may just close quickly, I did want to note that my co-author on this bill is Assemblymember Knight. We have joined together in a bipartisan manner to address this issue, and I look forward to hearing the results of the committee vote. Thank you so much.
I apologize for not letting you close. Thank you
Not
for
at all.
adding that.
Thank you very much.
Thank you.
Committee.
Now, next in order, AB 1640, presented by Ms. Evans.
Good afternoon, Mr. Chair.
Good afternoon. Welcome back.
Thank you. Members, I am delighted to present this bill today. This bill addresses a health care crisis in the Every Woman Counts program. The Every Woman Counts program is a program of state-subsidized breast cancer treatment program for low-income women. And back in December, the Department of Public Health abruptly announced 2 significant policy changes to that program that went into effect January 1. First was that the minimum age to receive breast cancer screening services under this program would be raised from age 40 to age 50. And second, and equally important, new enrollments would be frozen for the first 6 months of 2010. Members, you may or may not recall back in the summertime during our budget conference committee, we specifically denied this authority to the administration, and I realize that they argue with that, but the record is pretty clear that the legislature did not give them the authority to do this. So what this bill does is a couple of things. First of all, before I get to what the bill does, I do want to mention that as a direct result of these changes to this program, a number of things are occurring with respect to the administration of breast cancer screening programs to low-income women. The Elizabeth Center, which has been in existence in Los Angeles County for over 65 years, notified my office recently that they will be closing their doors as of April or May of this year as a direct result of these changes. We have requested that the state auditor do a study of this because the program is funded through Prop 99 tobacco funds and tobacco tax funds, and there's no reason why this program would go unfunded. It's frankly a mystery to us. So we have requested an audit, which will be coming back soon. What this bill does is it states the legislature's intention to reverse the administration's changes. So the two things that they did back in December, it states our intention to change that. And it does that for two reasons. One is to get the auditor's report back to determine whether or not there are changes that we should actually authorize as a legislature, and two, so that we can address the issue of how we are going to fiscally, financially restore this program to where it ought to be for the budget process. So there's no opposition to the bill. It's going to definitely save lives throughout the state of California, and I would ask for your aye vote. And I have with me two witnesses, Reverend Carolyn Dyson, as well as Laura Ewing.
Thank you, Ms. Evans. And witnesses, welcome this afternoon. Just run you 3 minutes for your witnesses in favor. Thank you.
Well, first, thank you for this opportunity. I'm Reverend Dyson. I'm Reverend Carolyn Dyson, and I manage at California Pacific Medical Center in San Francisco 2 programs for uninsured at-risk women, the African American Breast Health Program and the Sister to Sister Breast Health Program. And in that program, we bring in women who are at risk that have no insurance for the early detection screening mammogram. And my experience is that the women that we're finding to be positive are younger and younger. The last 3 positive breast cancer findings were women below the age of 50. I'm really passionate about this bill. A lot of that passion is based on my own family history. My mother, who was diagnosed with breast cancer at age 50, died at age 52 from the disease. My mother's sister, diagnosed at age 41, is now a 44-year breast cancer survivor. I'm now myself a 10-year breast cancer survivor, having been diagnosed 4 months after my daughter was diagnosed. She was diagnosed at age 35 and is also sharing with me, celebrating with me 10 years of surviving. Let me say that the journey for my daughter and I were quite different. At the time, she was an employee for the Social Security Administration and had really, really good insurance. I had no insurance, and I was seen at the time of my diagnosis through the early detection program under the state. And that program provided me what I needed to battle that breast cancer. I had been getting my annual mammograms through the program for about 4 years when I was diagnosed. So I'm saying that there are other women like myself who need to be able to say that this program being in place made a difference in their survival. And I ask you, with all of the passion that I have based on the 10-year survivor as an uninsured woman, to please consider this bill. Thank you.
Thank you.
Good afternoon, Laura Ewing, Community Health Councils. I have something to pass out. Thank you. This is some information on local impact data in Los Angeles County. I work for a community-based policy and advocacy organization. There's 22 signatures from leading organizations on this support letter for AB 1640. Our coalition members and stakeholders, many of which are local area clinics and providers, have been hit hard by the recent policy changes to the cancer detection program, Every Woman Counts. In Los Angeles County alone, approximately 30,000 women have been disqualified from the program as of the recent policy changes on January 1. The elimination of funding has shifted the financial burden of screening and diagnosis onto local community clinics and county facilities that are already struggling to serve their patients. Assemblymember Evans mentioned the Elizabeth Center, and I've been in close contact with Don Cook, who's the executive director there, and have heard the same bad news. Watts Healthcare Corporation, a local community clinic based on South Los Angeles, provided over 3,200 mammograms in 2008, of which 38.4% were received by women below the age of 40, and the clinic predicts that without the reversal of the recent policy changes, the majority of their screenings will be impacted. And this list of clinics and centers can go on and on. In Los Angeles County, where we are located, breast cancer is the second leading cause of premature death. Death rates for breast cancer are highest among women of color and lower income communities, but diagnosis rates are lower due to lack of consistent, adequate access to screening and diagnostic services for this population. A recent report by the Los Angeles County Department of Public Health reinforced the fact that uninsured and lower income women have drastically lower rates of obtaining a mammogram in the past 2 years compared to privately insured or higher income women. Unfortunately, the cuts to the EWC program disproportionately affect these women at increased risk for breast cancer mortality and will result in later stage of diagnosis and even poorer prognosis for the state's underserved women. The recent report from the U.S. Preventative Services Task Force reinforces the importance of an individual under the age of 50 and their doctor to have the opportunity to decide when to begin screenings according to the patient's individual risk factors. Eliminating all women under the age of 50 from the EWC program and ceasing in new enrollment does not exactly allow for the individualized decision-making when a woman no longer has access to breast cancer screenings. Additionally, women eligible for the EWC program are not the general under 50 population. These are uninsured, lower income women that otherwise would not be able to afford breast cancer screenings. We've all heard that catching cancer early saves lives and monies. The fact is the 5-year survival rate in California for the earliest, most localized breast cancers is 98%. Catching breast cancer later, more distant breast cancers have a mere 21% survival rate. If the policy changes are not reversed, long-term spending will increase due to extreme costs of treating advanced stage breast cancer. Unfortunately, the cost won't just be to California's pocketbook, but also to the lives of thousands of women. Thank you for your time.
Thank you. Any witnesses in opposition?
There might be other witnesses in support.
We do have a queue of witnesses in support. So I would ask you to please identify yourself by name and your position in support. Thank you.
Thank you, Mr.
Is the microphone on?
Thank you. Thank you, Mr. Chair and members of the committee. Carolyn Gino with the California Medical Association, here with a position of qualified support for the bill today, simply because we don't have final positions on bills ratified by our board yet, but we are absolutely supportive of what Assembly Members Evans and Nava are trying to do in ensuring that this population has access to these screening services. Thank you.
My name is Alice Knight. I'm Vice Chair of the Susan G. Komen for the Cure California Collaborative Public Policy Committee. I'm a 10-and-a-half-year breast cancer survivor, and if I hadn't had insurance, I would not be alive here today to be able to testify in front of you. We at Susan G. Komen for the Cure know that early detection saves lives, and is unconscionable to think that women who are 50 and under will no longer have access to this program. I was 47 when I was diagnosed. I urge you to vote yes, and I thank all of you for your time and attention on this important issue, because who knows, it could be you who loses your job, you don't have insurance, and then what would you do if you found a lump? Thank you.
Thank you for sharing your experience. I would remind witnesses now, please just identify yourself by name and announce your support for the bill. We have a full docket this afternoon. Don't want to cut anybody short, but want to afford all authors equal opportunity today. Thank you.
Alicia Sanchez with the American Cancer Society in support.
Jessica Bartholow with the Western Center on Law and Poverty in support.
Shannon Smith Crowley, American Congress of Obstetricians and Gynecologists, District 9 in support.
Bob Ackerman with the California Radiological Society in support.
Thank you. Any other witnesses in support? Seeing none, any witnesses in opposition? Seeing none, questions from committee members? Mr. Adams.
Thank you very much, Mr. Chairman. Ms. Evans, first of all, thank you for bringing this important measure forward. While I do have some modicum of reservation concerning the unfunded portion of this and where we're going to find that in the budget, as somebody who is deeply steeped in budget matters, I'm sure you're keenly aware of that concern as well. But I think on the policy itself, this is meritorious, and I'm looking forward to supporting it.
Mr. Adams, I would note this is not a general fund supported program.
Thank you. Mr. Nava?
Yeah, thank you. As the joint author, I think it's important to point out the cuts to this program are going to disproportionately impact women of color. The frequency with which the diagnosis is necessary for women of color is elevated, and the direct impact of not adequately funding this program will affect African American and Latino women more than others.
Any other questions? Mr. Gaines.
Yeah, just a question of clarification, because our analysis indicates that this would be an unspecified appropriation. And so I'm trying to, are you going to provide some sort of amendment language so we know that where the money is coming from within the budget?
The reason why we left this as having intent language is so that we can address this in the more appropriate. We can address the cost factor. In other words, we can fund this program again through the budget process. So that is yet to be determined. But right now it's stating the legislature's intention to reverse the changes that were made administratively with respect to the age at which screening should begin and the fact that eligibility was cut off for this 6-month period. So the money will come later.
Okay. Would that be clarified by the time it gets to the floor for a vote?
Yes. It should be long before then.
Okay, because from what I can ascertain, it's Prop 99 dollars that have been declining
Correct.
over time that's creating this problem currently.
Well, that's
Or is it
what
more
the
than that?
administration has said to us, but we held a lengthy hearing on this issue, and no one has actually been forthcoming with respect to the dollars actually involved in either the tobacco tax, the money available, and how it's been spent in the program. That's why we've asked for the audit. So the auditor's report should be back. And once we get in a couple of months, and once we get that information, we should then be able to address your question.
Okay, I think what I'll do is lay off until we have that funding question answered. I think that should take place by the time it gets to the floor.
Thanks.
Thank you.
Seeing no further questions, Ms. Evans, would you like to close?
Thank you. And I do want to say I was remiss in not mentioning my co-author, Mr. Nava. I appreciate his support on this issue. I do also want to mention, while this program is funded by tobacco tax monies and is not funded out of the general fund, we know that early detection saves lives. Yes. We also know that early detection, once cancer is detected early on, it is much less expensive to treat. So while this cut does not impact positively the general fund will in fact be paying for the cost because that's where our medical treatment is funded from. So this is actually going to cost our general fund money in the long run, and it is going to cost the lives of women and impact the lives of families throughout the state. I would ask for your aye vote.
Thank you, Ms. Evans. We still have yet to establish a quorum. So thank you for your presentation. We will hold your bill until we've established quorum. Thank you to your witnesses for joining us this afternoon. Now we'll go to AB 1701, Mr. Chesbro, followed by Mr. Hill. Yes, if the sergeants could contact our missing committee members and try to get them here so we can establish quorum. Good afternoon, Mr. Chesbro.
Good afternoon. First of all, to Mr. Monning, congratulations on your new chairmanship. I'm very excited that you're where you are.
Thank you.
AB 1701 will establish the Disease Prevention Demonstration Project as permanent. The Disease Prevention Demonstration Project of 2004, which was a bill by John Vasconcellos, allows cities and counties who are authorized locally to sell 10 or fewer hypodermic needles without a prescription. The purpose of the project is to reduce the spread of disease as a result of intravenous drug use. Since 2004, the program has been a success. Currently in California, we have 15 counties and 4 cities and 650 pharmacies participating in the program. According to the California Department of Public Health, the program has rolled out smoothly, and participating counties have had a positive experience. According to the California Department of Public Health Office of AIDS, no adverse effects have been reported by the pharmacies participating in the program, and I think we know that it has been successful in preventing the spread of serious and deadly diseases in California. I have with me today Bruce Palmer with the California Society of Addiction Medicine, as well as Dr. Ann Lindsay.
Okay, I'm Dr. Ann Lindsay. I'm Humboldt County Health Officer, and I'm the president of the Health Officers Association of California. So Humboldt County has a population of 127,000 people. So I'm going to tell you about needle exchange and pharmacy sales in Humboldt County, just to put a real face on things. In 1997, we paid 200 intravenous drug users in Humboldt County to allow us to take blood and test for various infectious conditions that were transmitted by blood contact. Only one was HIV positive out of the 200, but 75% were positive for hepatitis C, which indicated that needle sharing was going on. We also interviewed the injection drug users, and they said that the reason that they shared needles, which many of them did, was that they didn't have access to clean needles. It wasn't that they couldn't afford to buy them or chose not to. They just didn't have access. When needle exchange became legal in California with a county state of emergency declaration, Humboldt County supervisors were quick to take action. We established a needle exchange program in primary care clinics throughout the county, and there were 7 needle exchange programs in our small county, and they ultimately exchanged 180,000 needles a year. Our HIV incidence remains low. This past year, 2 of the largest needle exchange programs closed in Humboldt County for fiscal reasons, and basically cutting off 95% of the syringe exchange programs. The Humboldt County supervisors had also passed authorized pharmacy sales in 2005, but with the closure of the needle exchange program, these pharmacy sales programs became increasingly important. Now we have 8 pharmacies throughout the county registered with public health and participating in the pharmacy sales program authorized by SB 1159. The pharmacists, even who had initially had reservations, have reported they feel good about helping to promote public health, and they have no problem with consumers acting up in their pharmacies or causing difficulty. So having clean syringes protects law enforcement because they face exposure to dirty needles in the course of their work. It protects the intravenous drug users who actually, they have a chronic disease just like diabetics and hypertensive, and it can be treated. It need not be a death sentence. And also, it also protects the offspring and sexual partners of injection drug users. And it has been shown that the prescription sales, which are actually legal in all but 4 states, can significantly reduce the incidence of HIV, actually having it in states and cities that have pharmacy sale programs as compared to cities that don't. So as a Health Officers Association of California support 1701, we recommend that you do as well.
Thank you, Doctor. And I'm just going to interrupt for a moment. We've established a quorum. I'll ask the clerk to call roll.
Monning,
Here.
Adams,
Here.
Amiano, Carter, Conway, De La Torre, De Leon, Emerson, Eng, Gaines, Hayashi, Hernandez, Jones, Lowenthal, Nava, Perez, Salas, Smythe, Strickland.
Thank you. We've established a quorum. Thank you. Your second witness, Mr. Chesbro.
Bruce Palmer with the Health Officers Association of California. I'm not going to repeat, as Dr. Lindsay said, the Health Officers Association, physician health officers in California's 58 counties are in support of this.
Thank you. Any other witnesses in support?
Mr. Chairman, members of the committee, Randall Hager on behalf of the California Psychiatric Association. We're in strong support of this. This is a very important public health safety measure.
Stephen Mulhart, representing the California Association of Alcohol and Drug Program Executives, in support.
Glenn Backus, Drug Policy Alliance Network, in support.
Tom Riley with the California Academy of Family Physicians, in support.
Teresa Stark with the California Medical Association, in support.
Michael Radigan on behalf of the Board of Supervisors, Santa Clara County, in support.
Thank you. Any witnesses in opposition?
Second.
Bill's been moved and seconded. Would you like to close, Mr. Chesbro?
Just very briefly, Dr. Lindsay indicated that the penalty for the illegal use of narcotics should not be death, but as important, all of us are at risk, particularly children and spouses, of the spread of these deadly diseases. And this is a small step that we can take to continue to protect people. So I would ask for your aye vote.
Thank you. And before I invited you to close, I should have invited members of the committee if they had any questions. Any committee questions? Seeing none, there's a motion on the floor. Motion, I'm recommending a do pass.
Monning,
Aye.
Monning, aye. Adams,
Aye.
Adams, aye. Amiano, Carter, Carter, aye. Conway, De La Torre, De Leon, Emerson, Eng, Eng, aye. Gaines, Gaines, no. Hayashi, Hayashi, aye. Hernandez, Hernandez, aye. Jones, Lowenthal, Lowenthal, aye. Nava, Nava, aye. Perez, Salas, Salas, aye. Smythe, Strickland,
We're one short of passing that out. We'll put that on hold. Thank you for your presentation.
Thank you for your courtesy, Mr. Chair and members.
And next up will be Mr. Hill. Yes, and as you're getting situated, I would like to, now that we have a quorum.
AB 1593, Ms. Yamada, I'd like to move the bill.
Thank you. Mr. Adams has moved AB 1593. Is there a second?
And I'd like to also move AB 1640, Ms. Evans.
Moved and seconded, both AB 1593 and AB 1640. Would you please take the roll on AB 1593? I recommend a do pass, and that would head to appropriations.
Monning,
Aye.
Monning, aye. Adams,
Aye.
Adams, aye. Amiano, Carter, Carter, aye. Conway, De La Torre, De Leon, Emerson, Emerson, aye. Eng, Eng, aye. Gaines, Gaines, aye. Hayashi, Hayashi, aye. Hernandez, Hernandez, aye. Jones,
Jones.
Lowenthal, Lowenthal, aye. Nava, Nava, aye. Perez, Salas, Salas, aye. Smythe, Strickland,
That bill is out, and now we'll move to AB 1640. I recommend a do pass,
to appropriations.
and it would head to appropriations. Would you call the roll, please?
Monning,
Aye.
Monning, aye. Adams?
Aye.
Adams, aye. Amiano? Carter? Carter, aye. Conway? De La Torre? De Leon? Emerson? Eng? Eng, aye. Gaines? Hayashi? Hayashi, aye. Hernandez? Hernandez, aye. Jones? Jones, aye. Lowenthal? Lowenthal, aye. Nava? Nava, aye. Perez? Salas? Salas, aye. Smythe? Strickland? That's 10. It's out.
That has 10 votes. That is out as well. We'll come back to that.
Oh,
It was short.
I want to come back.
Mr. Jones can put that bill out if he wants to vote on that one.
On the Chesbro?
We just need one.
Yeah, just housekeeping. We have the Chesbro bill is a vote short. Could you please call the roll of absent members? I believe Mr. Jones has joined us on that. Chesbro bill, AB 1701.
Amiano? Conway? De La Torre? De Leon? Jones? Jones, aye. Perez? Smythe? Strickland? Has 10.
Thank you. That has 10. It is out. Thank you. Mr. Hill, thank you for your patience. Welcome.
Thank you, Mr. Chair and members. AB 1733 creates the Director of California Biotechnology Retention and Recruitment within the Governor's Office to foster the growth of California's biomedical industry through increased assistance and collaboration between state government, universities, and the private sector. The director would be appointed by and report to the governor and be funded using existing resources within the governor's office.
Second.
The increased coordination and assistance between state government, higher education, and the private sector resulting from this legislation will translate into higher quality jobs for Californians. Was there a motion and a second? Did I hear that? I did. Yeah. Well, then I could go on forever on this subject, but I won't. I just wanted to let you know that just briefly that California's biotechnology industry, and just to give you a few facts, and that was beyond, and then I'll wrap it up. We are home to over 2,000 biotech companies. We employ over 274,000 people. The average wage is over $75,000. We've created 1,200 approved treatments with 869 products in the biopharmaceutical pipeline. This legislation is important because competition is fierce in the biotechnology companies. 45 states, 27 countries have organized efforts to attract biotechnology companies away from California. But more importantly, this sector alone is one of the few, if not the only sector in the past year that has actually increased employment in California rather than lost jobs. So I would ask for your aye vote.
Thank you. Witnesses in support.
Mr. Chair and members, Michael Hawkins. I'm representing CHI, the California Healthcare Institute, represents 270 of the life sciences biotech companies in California. This is a very important piece of legislation. Other states have very aggressive recruitment activities that take place in California. The governor of Texas comes to California on a regular basis and meets with these companies and, in fact, has been successful in having growth take place in Texas rather than California. So CHI is very supportive of this legislation and encourages all members to vote aye. Thank you.
Mr. Chairman and members, Maureen Higgins representing Biocom and its 500 member companies in life sciences, biotech, and medical device companies. We're strong support of this legislation also for the reasons that Mr. Hawkins cited, but also it's a very heavily regulated industry at all levels of government, federal, state, and local. And many of our companies have difficulty navigating the different requirements in state government. So for both the retention reasons and those reasons, we're in support of this bill. Thank you.
Thank you. Other witnesses in support? Are there any witnesses in opposition? Questions from committee members? Mr. Hill, I have a question. The bill indicates that there's that the governor would establish this position using existing resources. Do you know what's contemplated in terms of that appointment? Is there support staff? What are the resources that would be required?
No, our assumption is that as soon as, if the bill passes, when and if it passes, we would then, and the industry would work with the governor's office to see how best to move forward with the implementation of the bill. We think it's important to do this. One of the challenges that the industry has faced is certainly the potential loss of good business and jobs, and we would hope that this could prevent that in the future, preserve those jobs, bring increased revenue into the state, and perhaps if we could have had done this many, many years ago with certain industries, we would have had and been able to preserve those, especially in the gray economy, as we've heard lately.
Great. Well, I appreciate that, and I think maybe that's a question better that'll be directed to you in appropriations. So,
yes, I think so.
But for the Health Committee, we do have a motion and a second. Any questions from committee members? If not, would you like to close, Mr. Hill?
I respectfully ask for your aye votes, member.
Thank you. We have a motion, and I have a recommendation of a due pass. This will be referred to appropriations.
Monning?
I correct. That's going to BMP first.
That's
and on
right.
the vote, yes. Aye.
Monning, aye. Adams?
Aye.
Adams, aye. Amiano? Carter? Carter, aye. Conway? De La Torre? De La Torre, aye. De Leon? Emerson? Emerson, aye. Eng? Eng, aye. Gaines? Hayashi? Hayashi, aye. Hernandez? Hernandez, aye. Jones?
Thank you, Ed.
Jones, aye. Lowenthal?
Thank you.
Lowenthal, aye. Nava? Nava, aye. Perez?
You ready to go?
Salas? Salas, aye. Smythe?
Take them in
Strickland?
order. Take your first.
Strickland, aye.
Thank you, Audrey.
Thank you, Mr. Hill.
Thank you, Mr. Chair. Thank you, members, for your support.
And you're out of committee. We're going to go out of order here and invite Member Jones to come forward. He has two bills. I understand on one he'll be joined by Mr. Fuhrer, who has a plane to catch. So as a courtesy to the former chair of this committee and my colleague, Mr. Fuhrer, we will proceed with Mr. Jones' bills at this point, and then we will come back in file order. Welcome, Mr. Jones.
Thank you, Mr. Chairman. With your permission, then, we'll start with the bill that's jointly authored by Mr. Fuhrer and I, if that's acceptable to the chair.
That's fine. Give us the bill number.
That's Assembly Bill 2578.
Okay.
And we have a couple of witnesses as well.
Okay, that's file item number 16, AB 2578. Welcome, Mr. Fuhrer.
Thank you, Mr. Chairman. Thank you, members. All of us have no doubt received calls and letters and conversations on the street from our constituents about the extraordinary up to 39% rate hikes announced by Anthem Blue Cross the other month. The sad fact is that Anthem Blue Cross is not alone in these rate hikes. In fact, we've had double-digit year-to-year rate hikes in this state, something on the order on average of about 130% increase in health insurance and health care premiums since 1999. And as consumers continue to get hit time and time again, it's no wonder that so many Californians can't afford health care. There's also been tremendous profit-taking, something we discovered in this committee's hearing the other month on the issue of the increases in rate hikes. From 2007 to 2009, Blue Cross of California passed $2.75 billion in profits to its parent company, WellPoint, in the form of dividends, and WellPoint made $4.7 billion in 2009 alone. At the same time, consumers continue to suffer. What this bill simply does is build on the very successful prior approval approach of Proposition 103, which has worked very well in this state since 1988 for auto, property, and casualty insurance, saving consumers tens of billions of dollars, but also making sure that the industry can continue to stay in business in this state. This bill would simply apply a prior approval regime to health insurance and health care products so that before rates are increased, the approval of either the Department of Insurance for Health Insurance or the Department of Managed Health Care would be required to be obtained, and excessive and discriminatory rates could be rejected. Now, I think it's important to note that on this very day when the President signed a very momentous national health care reform bill, that bill while it will do wonders to bring many more Californians to having health insurance and assist in making sure that pre-existing conditions are no longer an impediment and provide subsidized insurance to many. What was missing from that bill, as Senator Dianne Feinstein and the President themselves both acknowledged, is any prior approval or regulation of rates. And the grave risk we run here is by mandating that all Californians get insurance, that we will continue to have excessive raises in rates. In fact, that is what happened in Massachusetts, which adopted about 3 years ago a very, very similar form of health care reform, similar to what the federal government just enacted, and they saw rates rise precipitously. So with that, I'd like to turn the mic over to my joint author and respectfully ask for your aye vote.
Thank you very much, Mr. Jones. I'll be very brief. The history-making effort that Mr. Jones referred to in Washington, D.C. can be mirrored here today and in the coming months in the Capitol, because for people who have health insurance, and particularly those people who have it but are struggling to make their payments, this legislation is history-making too. I would bet that every member of this committee, no matter what side of the aisle you're on, have been inundated with complaints from constituents saying, please help me deal with these dramatic increases I've just received. This bill is a common sense response to that constituent's ask of you, because it says if the insurer can justify a rate increase, then the rate increase can take effect. But that rate increase should be scrutinized to be sure it's justified first. I'll give you a sense of a couple numbers and conclude. Healthcare costs last year increased by about 4%. The increases that your constituents and mine received approximated 40%. Are they justified? Well, not on the basis of healthcare cost increases, they're not justified. Is there another basis on which to justify them? Perhaps. But just as Mr. Jones said we do for auto insurance, shouldn't we, for something as crucial as health insurance, give your constituents and mine the assurance that those increases are merited? Not caused by an investment decision, not caused by the decision to send profit from one corporate entity to another, but justified on the basis of common sense criteria delineated in the bill. History in Washington. Let's make history here too, that our constituents can see and touch and feel when they get those envelopes in the mail posing the increases that they're likely to receive. I urge an aye vote.
Thank you, Mr. Fear.
Mr. Chairman, we do have some witnesses who would like to address the committee with your permission, and perhaps we can take each of those in turn and they can identify themselves in order to expedite things.
Jerry Flanagan, Healthcare Policy Director for Consumer Watchdog. I'll be very brief. It was our founder, Harvey Rosenfield, who wrote Prop 103 in 1988, which regulates auto insurance premiums, which is the base model for this bill. That piece of initiative was written right after the legislature required the purchase of auto insurance. Following that reform, insurance rates went way up because the auto insurance companies found that, wow, I have a captured market, I can raise rates. Prop 103 has been extremely effective. It has saved drivers alone $62 billion in California through the prior approval process. California has the best experience with auto insurance rates going up just 12% since 1988 compared to 50% in the rest of the nation. And also it includes an intervention provision where groups can intervene in rates to make sure that they're fair. Our organization alone has resulted in $1.7 billion in savings in medical malpractice and auto rates since 2004 alone. I also want to say it's not just Blue Cross that needs this legislation. It's the nonprofits, Blue Shield and Kaiser as well. Those two nonprofits have over $13 billion in excess reserves on hand. That's enough money to provide health insurance to 900,000 families for an entire year. This legislation will require companies to get approval prior to getting those rates into place. If we're just talking about medical inflation driving up health insurance rates, they won't have any problem and they'll get approval. But if they're gouging consumers because we have a collapsed market, we'll get the kind of rate control we need. Thank you very much.
Hello, I'm Laurel Coffer. I've been a Blue Cross insured for 25 years. I have an individual policy. I'm a single parent, a sole business owner with 2 children in college. I got that letter in January. My rates have gone up, are going up 34%, from $832 a month to over $1,100 a month, which means with my $1,500 deductible, we need to spend roughly $14,000 to $15,000 a year before we get medical coverage. We need this legislation not tomorrow but yesterday. Please do this for us. Thank you.
Thank you. And now we'll hear from other witnesses in support.
Hi, my name is Fred Naranjo, and I own a company called Scarborough Insurance Agency, and I represent a lot of the different carriers here. These increases that we've been seeing in the past have been very difficult to deliver. 75% increases, 65% increases, averages that are coming from Blue Cross and Blue Shield. Our economy is in trouble, because once we're presenting these types of increases, the employers are saying to us as well as individuals, how can we afford this? And the effect is that they have to start laying people off in order to pay for these increases and jobs that are going away permanently. Also, what's really, employee benefits affects the bottom line to businesses. We have got to start doing something and just having these carriers justify the type of rate increases that they're coming out with. I used to work for Blue Cross of California in the marketing and sales department about 15, 20 years ago. We took pride because we would say when we were making our sales pitch that we gave back to our members out of every single dollar, 96% back to our members in terms of medical care. Today, that's not happening because a lot of the money is now, since they went from nonprofit to profit, is now being driven by expectations of the marketplace for a lot of these different carriers. The money is leaving from San Francisco, from California to back wherever their corporate headquarters. And I really believe that we need to have a committee that regulates from, profit and loss ratios and allow them to make money. But I don't think that we need to gouge our members, and especially when it comes to compensation. You remember the U.S. Aetna merger. The CEO got approximately $950 million for selling that company. WellPoint, 20 executives shared in over $1 billion in compensation. And those could have taken care of many, many Californians that are uninsured, or especially the middle class that are trying to do the right thing and pay for their health care and not being able to afford health care. Health care, I believe, is a right. It's not a tangible item. And, there are carriers that I'm pleased with. One happens to be Kaiser, because if you look at Kaiser, they have put back, I think it's 94% return from every dollar that goes into premium into health care here in California, either new modern technology, new hospital. And I think as a member, as my employer groups, they're going to benefit that because they're the only ones that have put in the technology, the new hospitals, the new infrastructure that hopefully will reduce the premiums in the future. I beg of you people, please, we need to have some regulatory bodies that prevent these huge increases and that are just taking our money away back out of the state of California when we need it to stay here. Thank you.
Thank you. And I would remind authors we have a two-witness rule, although I will say that group of three stayed within the 6-minute rule. For those now testifying in favor, I ask you to identify yourself by name, by organization, and offer your support. But this, unfortunately, is not a time for further testimony, just to state your position. So welcome this afternoon. Please state your name and your support for the bill.
Thank you. Jerry Gonsalves with AARP, and it's 3.1 million members in support. Thank you.
Thank you.
Lori Sobel with Consumers Union in strong support. Thank you.
Monica Miller on behalf of the California Chiropractic Association in strong support. Thank you.
Jeremy Smith on behalf of the California Labor Federation in support.
Beth Capel on behalf of Health Access in support.
Shane Gussman on behalf of the Teamsters, United Food and Commercial Workers, the Machinists, and the Amalgamated Transit Union in support.
David Warren, I'm just representing myself because my premium went from $600 a month to $1,100 a month in the last 9 months.
Dolores Duran Flores with the California School Employees Association in support.
Pedro Morillas from CalPERG, also in strong support.
Ignacio Hernandez on behalf of the Consumer Federation of California in support.
Jerry Bailey, Single Payer San Joaquin in support.
Thank you. Seeing no further witnesses in support, are there witnesses in opposition? Please come forward. And again, we'll take 2 witnesses with a 3-minute time allocation, and then others can offer identification and voice their opposition. Welcome.
Thank you. Good afternoon. Ann Iowan with the Association of California Life and Health Insurance Companies. I think what you've heard today is a common concern that we share as well, and that is that costs are going up. What we are concerned with, though, is that any independent study you want to look at, insurers are not the cost drivers that are out there. In 2009, according to a report from the Department of Health and Human Services Centers for Medicare and Medicaid Services, rising costs for hospitals, physicians, and prescription drugs led to the largest growth in healthcare spending as a share of GDP since the government started keeping track 50 years ago. And a lot of that is because providers have gotten smarter and they are organizing into larger groups and they have a lot more bargaining clout. And all that goes on top of medical trend. As payers, we have very little control in terms of controlling costs. We can try and do better quality, we can try and negotiate better rates, but we are not the cost drivers, so it's difficult to control the kind of costs, the underlying costs that are the result of the medical inflation and the additional trend on top of that. What's been suggested is that the real driver here is outrageous health plan profits. And I would just point to the fact that health plans have some of the lowest profits in the entire healthcare industry. Overall, it's 11%. For health insurers, it's 3.4%. And it's not just us saying that. That's been on the news since all of this has been going on. Drug companies are close to 20%. So if the goal is to suppress insurer profits, how much farther down can they go? Under Prop 103, the average under a rate-regulated system for auto insurers is 3 to 8%. How much farther down are health insurers supposed to go in terms of their profits, and what will it accomplish? And I guess that sort of begs the question, doesn't it? Why would we be setting up a very expensive in 2 different departments, a very new, expensive process? In the Department of Insurance, it costs about $22 million a year to run. All of that comes out of premium payers. This would be duplicated in 2 departments. And I would have to say that auto insurance is infinitely less complicated than health insurance. Now, proponents argue that Prop 103 has saved millions and millions of dollars, but it does not take into account the millions and millions of dollars that have gone into the rate regulation process itself. And this is not just Prop 103, this bill. It's actually far more than Prop 103. It'd require every single copay, every single deductible, every single bell and whistle or change in a health plan policy to go through this rate regulation process, and you can only file once a year, inundating the department with thousands and thousands and thousands of pages of rate filings. I would have to say, too, that it also, as was suggested about interveners, and I'll just finish up here, last year alone, interveners got $2.5 million in premium dollars. And since 2003, they've gotten $10 million. We have to put that into the cost as well. And with federal health care reform, 80%, 85% MLRs, as well as the new rate approval authority that's in the federal law, and the fact that carriers are going to have to be submitting their new policy forms to the department and just to meet the federal law, I think that this bill is premature and we should wait and see. So we're asking for a no vote.
Thank you. Next.
Mr. Chair and members, Bill Worley with Kaiser Permanente. We had the pleasure, our CEO had the pleasure of joining President Obama at the White House. We're an enthusiastic supporter of this landmark legislation. But one of the things that, frankly, we think was the right outcome was to leave the decision about whether to go down this path, there's a discussion of the bill today, up to states, and we respectfully suggest that it is not a good path. And we come at that from considering two scenarios. The first scenario is perhaps the easiest one. What if the regulators, you grant them all of this power over 1/6 of California's economy and they do nothing with it? Well, then we've spent millions upon millions of dollars arguing and litigating over what might be called the inevitable. We've seen that in Prop 103. Ms. Ioana alluded to the annual budget of the Department of Insurance of $22 million. What is that accomplishing? We don't want to see one nickel go out of the healthcare system. And that's if the regulators don't act with the kind of power that this bill would grant them. On the other hand, what if they do? Kaiser Permanente exists, as some of the members know, in states other than California, although obviously we're pretty much focused here in terms of our membership. In the state of Hawaii, we had the experience of having the industry-leading electronic medical record system that we're deploying throughout our system, which ironically the proponents testifier mentioned, that we think is going to do amazing things for healthcare. We had to delay that and lay off the people who were putting it in for a year and a half because the regulator in Hawaii arbitrarily decided that we couldn't do it because our rates were not sufficient. So we look at this system and we see, or the proposed system, and we see the dangers either for doing nothing because of the waste, frankly, that it involves, or the temptation to act. And we have to ask, well, why should we do this? Kaiser Permanente's margins over the last 5 years were a not-for-profit system, and we're happy to tell you where every penny, including our alleged excess reserves, go. They go to, for example, keeping us solvent during the worst worst recession since the Great Depression. But they also go to covering 77,000 children, to providing care for 6.5 million members, and to building new facilities around the state, and that's it. So on top of that, we look at the fact that we looked at the 13 large states in this country that already have rate regulation, including Massachusetts. 10 of those 13 have higher premiums than California does. So we have this situation where we are tempting, we think, very dangerous power and the opportunity to really create problems for patients, and we're not seeing what is the record of benefit. And thanks for the indulgence.
Thank you, Mr. Worley. Other witnesses in opposition?
Charles Bakke with the California Association of Health Plans, also in opposition. Thank you.
Thank you.
Michael Hawkins on behalf of CAPG, the California Association of Physician Groups, representing 150 groups and 50,000 physicians strongly opposed.
Thank you. And now at the floor microphone, please state name, organizational affiliation, and your opposition. Thank you.
Angelica Gonzalez with Anthem Blue Cross in opposition. Thank you.
Teresa Stark, California Medical Association in opposition.
Marty Fisher, California Chamber of Commerce, also in opposition.
Suzanne Sutton, California Taxpayers Association in opposition.
Julie Broyles, California Association of Joint Powers Authorities, also in opposition.
Maureen Higgins, representing America's Health Insurance Plans, in opposition.
Dan Chick with HealthNet in opposition.
Thank you. Seeing no further witnesses, let me see if committee members have questions. Seeing none, seeing one. I'm sorry. Ms. Strickland, sorry. Go ahead, Ms. Strickland, then you'll be followed by Mr. Eng.
How was your bill affected by the federal passage of its health care bill?
The bill is complementary to the federal health care reform bill and actually made more necessary by the federal health care reform bill. The federal health care reform bill will mandate that most Americans get health insurance. And what happened in Massachusetts when that occurred was essentially you moved 750,000 lives with a mandate requiring them to get insurance, and the health insurance industry acted as a rational economic actor and raised prices. And so this is a piece that is complementary to and fills a gap in the health care reform package, and appropriately so.
Do you, in your bill, require the health plans to maintain their current quality of care that they offer to their customers?
The bill has a number of provisions that are designed to make sure that the regulators take into account the health insurers and health care plans expenditures with providers. The ironic thing about the opponent's argument that somehow this will harm providers is that, as we heard in our last oversight hearing, the health insurance industry and health care plans are already squeezing providers down. We heard from physician after physician, provider after provider, that they routinely are pushed to lower their levels of reimbursement below what their costs are. What we've designed in this bill is a mechanism that provides that when prior approval for a rate increase is sought, information is provided to the regulators with regard to what their medical costs are so that the regulators can take that into account in setting the rates. And that is essential. We want to make sure that we are providing for care. What we want to try to squeeze out of the system are the excessive profits we've seen year after year here
Mr.
in
Jones,
California and
I
elsewhere.
appreciate that. I think my question more is about the quality of care that these people are receiving, any of us who go to whatever doctor we choose to. Do you require the health plans in your bill to maintain the current level, the standard of care that they're currently offering?
Again, our bill is focused on the regulation of the rates themselves. All of the existing statutes that exist in California with regard to quality care are not preempted by this. The existing mandates, the provisions in the federal health care legislation as it relates to banning pre-existing conditions, getting rid of a variety of different ways in which, frankly, the health insurance industry has reduced care are operative. This bill does not undermine any of those.
My concern is that while you're regulating premiums, co-payments, co-insurance, deductibles, and all of that, that will come at a price. And I suspect that at some point, if you're not allowed to raise premiums as costs go up, that it either means that they have to reduce the quality. You're shaking your head.
No, quite the contrary. You can raise rates under the bill as costs go up. This bill provides for increases in rates as true medical costs go up. What it does not allow for is rates that are providing for excessive profits. But true medical costs, this bill provides that rates would go up. And I think
Does your bill set a rate for excessive profits? What is that definition?
The same definition that's been used successfully in Proposition 103 for auto, property, and casualty insurance.
Which is what?
That has allowed those industries to continue to make healthy profits and healthy returns. You heard some of the averages from the
What
witnesses.
is that percentage?
Again, it's case by case, and it's based on the applicant and the situation.
Who sets that percentage?
Again, it's based on years of experience going back to 1988.
That may be. Who sets the percentage?
In this case,
Yes.
in this case, it would be the Department of Insurance and the Department of Health Care, but it's not a percentage, because the key is to make sure that they are providing quality of care, that true medical costs are being provided for. So it's
how
not
do you
some
determine-
arbitrary figure. You look at
That's
the rate.
fine. But you just said it's on a case-by-case basis, so doesn't that make it arbitrary?
No, not at all.
Can you explain
You use ratings factors. You use an analysis that looks at what their costs are and whether they need a rate increase to make costs and whether they're providing decent shareholder returns.
Okay, so there's a set formula in the Department of Insurance and in DMHC, a set formula that will determine when and how they're allowed to increase rates.
There are factors that they use in looking at each
Is
rate
that set forth in your bill?
Yes.
Okay.
Yeah.
Just the reason why I ask about the quality of care is because the number of people that have access to care, the quality of the care, and the cost of the care are all very interrelated. And if you attempt to arbitrarily fix one over another, that you're going to obviously impact the others. If you are fixing the price, it's going to affect the quality of care because there will be a lesser number of dollars used to provide care or to provide access to more people. I mean, it's just the market. And so if your bill doesn't require the health plans then to maintain a certain quality of care, and it dictates how much can be charged. If your bill then doesn't also require these plans to operate in California, is the state prepared to assume the clientele of a plan that leaves the state because of your bill?
Look, I think it's important to understand that this bill doesn't change any of the existing statutes relating to quality of care. And importantly, the federal government just adopted federal legislation that requires that 85 cents on every premium dollar go into health care. That will dramatically improve the quality of care because right now many health insurers are putting far less. This bill operates within that construct, and so the 85 cents for every premium dollar going into health care is a requirement that applies as this bill is implemented. So things are going to get better, thankfully. What this bill addresses, though, is the enormous run-up in rates that's not related to medical cost increases, but rather related to profit taking.
My concern is that we are arbitrarily and subjectively setting limits that will potentially jeopardize the quality of care that each of us receives when we visit our doctor or a hospital, and that it will also affect access. I believe that they are all interrelated, and I'm without making a statement as to whether or not costs are necessary, the cost increases are necessary, but my concern is that we are going to be jeopardizing the quality of care that each California receives, and that we jeopardize the access for those individuals now. That's just my point as we proceed here, that I'm concerned about those areas. Thank you.
If I might just say very briefly to the committee, the bill says to insurers, if you increase your rates by 7% or less annually, you don't go through the rate regulation process at all. It's only if you increase your rates by, say, over 3 years, more than 21% during that period of time, 7% a year. That's when the approach of this bill is triggered. And what does triggering mean? The term arbitrary absolutely misstates what the bill would require. Instead, the bill sets forth a series of objective criteria that must be evaluated by the Department of Insurance, or DMHC, in advance of allowing a rate to be approved. And the critical elements of that analysis are, what insurer are you spending to deliver medical services? It rivets the attention of our regulators on exactly the issue, Ms. Strickland, you're talking about, which is, what are you doing to improve the quality of health for your insureds? That's the key.
Thank you, Mr. Fuhrer. Mr. Eng?
Thank you, Mr. Chair. I have a question, but I'll make a statement first. I have a concern that there seems to be kind of a broad brush approach between the profits and the nonprofits. And I voted for AB 1524 because there was a trigger to the medical loss ratio. And I feel that that type of trigger does protect nonprofits who invest their money into new equipment, technology, et cetera, et cetera. They're limited to a very, very small profit margin. And so my question is this. In the conversation we had previously, is it your understanding that the Obama administration healthcare proposal that has yet to be modified by the Senate, that has an automatic 8515 trigger in it, in the bill? And I think you answered yes, right?
Yeah, the Obama Democratic congressional health care legislation mandates an 85% medical loss ratio. So every health insurer, every health care plan is going to have to put 85 cents on the dollar into health care.
So my question is this. As you know, there are several lawsuits being contemplated that could go to the Supreme Court, which could render parts of the Obama administration plan unconstitutional, even though you and I may feel otherwise. There are attempts to opt out by several states, and that could reach the Supreme Court as well. Would you be willing to amend back in to the bill, which you had in 1524, the medical loss ratio of 8515?
Only if it removed opposition to the bill. When we had 1524 last year, we did have that language, and yet all of the opponents here, including the nonprofits, still opposed the bill. Essentially, we were told by Kaiser and others that there was nothing I could do in the bill that would take them out of the bill. Nothing. And I offered to take them out of the bill explicitly. And they said, no, thank you. We are opposed to this no matter what. And so I'm always happy to work constructively with the opposition. And if it were to remove opposition, I'd be happy to do that. But I don't want to have to go through the same exercise I went through last year where I did those things, and yet all of the opposition still remained opposed. And let me try to go directly then to the point. We have included language in here, and I want to just refer you to page 5 of the bill, lines 16 through 19, and this is just in one place, it's in several places, that requires that when the rate application is made, that the insurer or the health care plan will provide a line item report of true medical expenses, including aggregate totals paid to hospitals and physicians, the amount paid to applicants for the 100 most common medical expenses incurred by enrollees during the previous calendar year. So we've included language in here to make sure that we're getting and we're basing decisions on what true medical costs are. But when the opponents tell you that the medical costs are the only driver, they're not being accurate. What the Department of Labor has told us, which annually discloses information on medical costs, is that true medical costs are going up by about 3 or 4% annually in the United States. Health insurance premiums have gone up double digit in the state of California annually, almost as far back as the eye can see. So yes, medical costs are going up, but premiums are going up a lot higher. And that's why a company like Anthem Blue Cross makes $2.7 billion in the middle of the Great Recession. That's why WellPoint, at a time when companies are not making money, and remember, they're not producing a good, they're not making a good. They're taking people's money and making profits on people's money when people are trying to get health care. That's why WellPoint, in 1 year alone last year, makes $4.7 billion. They are squeezing down reimbursements to providers, and they are jacking up rates. And what our bill does is make sure we provide for true medical costs inflation so that the providers get what they need, but at the same time, we don't provide for these excessive profits.
I could just make one final statement, Mr. Chair. I appreciate it. Let me be clear about, I think the bill is well-intentioned. My concern is that by controlling rates, you don't necessarily have a result in which the services are maintained or increased. That's my concern. I happen to feel that it's a new day, and that whatever work you and I may have done last year on any matter, I do believe that this is a new time in terms of the economy and also in terms of what happened in Washington. Would you pledge to me that despite your preconceptions about what the opposition said to you, to work to address their concerns, particularly the nonprofits, because I do have a concern that they not be painted with a broad brush with everybody else, because I happen to know I had my first job with them. I can tell you they really keep their costs down.
No, there's no question. I mean, I think.
And if I can get your assurance that you will meet tirelessly with them, I will support the bill to get it out of this committee. But I'm going to reserve the right to look at that bill very carefully if and when it comes to the floor.
Absolutely. I'm very happy to sit down.
And I think you're capable of doing that. I think you've
Very
been very magnanimous in meeting with members as well as meeting with constituents. But I want you to try again, because I believe that that there could be a solution that would be found here.
I'm very happy to do that, and I would welcome your participation in those conversations, and I'm happy to make that commitment.
Thank you.
Thank you, Mr. Eng. I have Ms. Salas, followed by Mr. Adams, and hopefully we're getting close to conclusion here. We have quite a hefty docket this afternoon. Ms. Salas.
Thank you, Mr. Chair, and I think that we're here for the purpose of addressing some of the concerns that have been raised by people that are on both sides of the bill, and that is, how do we ensure that the medical dollars that the consumer spends are going to the most direct medical care that they can get? And I think that that speaks to the concerns of what some people were saying, is that if you're going to be regulating the amount of profit that the insurance company makes, how does that translate into the care that the consumer gets? And I think that we had a witness here that stated very clearly what that means. She stated that she has a family and she's spending $15,000 a year on premiums, and yet is not getting the kind of quality care that she needs. Where is that premium dollar going? And I think that that speaks directly to the intent of what this bill is. This bill is about transparency. This bill is not about limiting whether or not a premium could be raised or not. It's about making sure that if there's a necessity to raise the premium, that all factors have been considered in making that premium adjustment. And it's as simple as that. And when we see that the cost of premiums have soared way above the inflation rate for medical cost, you stated that it was 3 to 4% on the medical side of it, and yet we've seen premiums soar, in the double digits. This is what this bill is about, and we should not be afraid of transparency. If a rate increase is justified, then I don't see why a health care insurance company would be so afraid of going before a panel and saying, I need this rate increase because my overhead costs have gone up, and it's necessary for me to be able to continue to conduct business in making this rate increase. It's about transparency. It's the same kind of transparency that the health plans are asking of the hospitals. Now, the health plans have come into me and they've said, the reason that our premiums are going out of sight is because the hospitals and the doctors are charging so much. And if only you would make the hospitals and the doctors disclose what they're charging and what the consumer is getting, then everything would be great and we wouldn't have to raise our premiums. So it's about the transparency. It's about letting the public know what they're getting for their dollar. And if it's justified, they shouldn't have a problem in having that examined.
Thank you, Ms. Salas. Mr. Adams.
Thank you very much, Mr. Chairman. No, it's not about transparency. It's about control. It's about the ability to dictate what you believe is affordable and what you believe is profitable and what shouldn't be profitable. The fact of the matter is the Obama administration went forward with a similar plan, but all they did was sanction the idea that there should be that transparency. They didn't take control for themselves the ability to determine what or what not should be appropriate in terms of a profit level. And it is noteworthy, as Mr. Chairman, I might note, that the previous chairman of this committee actually spent time discussing this question just a few weeks ago with the folks from WellPoint, and it came to light that they, in fact, are completely within the norm of healthcare companies, both profit and nonprofit alike, between 3.5% and 5% profitability across the board. The reason we're spending so much money in healthcare in this state and across the United States is because of one unfunded mandate after another. Forcing companies to do something that is not profitable for the sake of feel-good politics, I think this is a horrible bill, and I can't wait to vote no on it.
Thank you, Mr. Adams. How do you really feel? No, with all due respect, I appreciate your comment. And we have Ms. Lowenthal. Nope. Other questions? I just wanted to offer a commentary as well. As I read the bill, there is no arbitrary percentage imposed. It is based on objective criteria. It's based on looking at what are the costs. If there's rising costs of doctors, of hospitals, of reimbursements, that's factored in. This bill I look at through the lens of ratepayers and consumers, and that if it brings more daylight to how rate adjustments are made, it's worthy of our support. So I want to, seeing no further questions, I would like to, Mr. Gaines.
Thank you, Chair Monning. I just want to comment because I think part of what's being missed here is the quality of care that is being provided for health insurance in the state of California, and it's a very high level of care, and that level of care is very expensive. And then you start getting yourself into a question in terms of, do you want the best care that may be very expensive versus trying to contain costs? My concern is that you start shaving down the profit margins of insurance companies to the point where they cannot do business in the state of California, and I fear with the Obama plan that this will happen nationwide. There'll be basically a forcing out